morning, everyone, and welcome to today's webinar, Staying Community Savvy, Working Within Your Environmental Health Network and Engaging in Risk Communication. My name is Rena McIntyre. I am the Manager of Environmental and Occupational Health at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I want to acknowledge that I am on the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabeg, Wendat, Huron, and Haudenosaunee Indigenous peoples, land that today is home to many diverse First Nations, Inuit, and Métis people. As someone who works in environmental health, I am grateful for the environmental stewardship of Indigenous peoples who have protected, shared, and cared for these beautiful lands since time immemorial. Today is the second of our two-part April webinar series on effectively navigating environmental health issues. And now it is my pleasure to introduce Rena Chung, who will speak about some of our work here at PHO. Rena is the Senior Director of Operations for the Population Health Portfolio at Public Health Ontario, and she holds more than 2 decades of experience working in the fields of environmental health. Rena, over to you.
Thank you, Elena. I'm pleased to be here this morning and talk a little bit about Public Health Ontario and environmental and occupational health, and really excited to hear today's presentation by Dr. Ray Copes. So for those of you who are new to our organization, Public Health Ontario provides the scientific evidence and expert guidance that shapes policies and practices for a healthier Ontario. A component of our legislated mandate is to provide education, such as this one, and professional development opportunities for public health professionals. Our goal is providing these opportunities will build skills, capacity, and competencies in Ontario's public health workforce to face tomorrow's public health issues. Today's webinar has been designed to support informed decision-making when navigating complex environmental health issues. And we do also provide training support in these other areas throughout our organization, such as communicable and infectious diseases, emergency preparedness, and infection prevention and control. But today we're really focusing in on environmental health issues as well as risk communication. So by the end of this session, our attendees will be able to identify opportunities to engage external partners when addressing local environmental health issues, describe key principles of risk communication for public health practice, and describe some strategies when engaging audiences in risk controversies. But before we get into that, we're going to tell you a little bit about the environmental and occupational health team here at PHO. One of the things that we are really proud of within the environmental and occupational health team is just the breadth of experience and support that we can provide. So the team itself is made up of physicians, epidemiologists, public health inspectors, occupational hygienists, toxicologists, engineers, risk assessors, microbiologists, and environmental scientists. And the 3 dots there goes to say that that is just a snapshot of the experience that's provided on the team. And one of the reasons we are really proud of this is because that we can offer different perspectives on very complicated issues when it comes to environmental health. And the way that we do that is we provide service through scientific advice and support. We do that through research, and we do that again through these sorts of education, knowledge translation activities. What we don't do, which is really important to emphasize, is that we do not set any kind of standards. So for those of you who attended the previous session, we'll have heard from our colleagues at the Ministry of Environment, Conservation and Parks, who are really the experts at setting standards for setting environmental standards. We don't assess compliance or make policy, but we can support health units, which I will go into some detail, in providing interpretation when it comes to those standards. So just a small difference between us, what we do and what we don't do. So if we think about the work that we at PHO do in the environmental and occupational health team at a glance, there's different kinds of products and services and lines of work that we get into. When we think about the support that we provide, they are typically within scientific and technical support, and they come in various forms, and we're happy to explore different ways to support our partners when complex issues arise. We also do research. Currently, we have some Health Canada funded work that is looking at climate change and Ontario's heat warning and response system. We're also doing work along radon. So we look for different opportunities that can advance environmental health in the province. We also do environmental health tracking and surveillance. Indicator development is something that the team is very passionate about. And of course, professional development, such as this series. And just while I have everyone's attention, we'll give a plug to say that with respect to professional development, in June, we will be offering a two-part series on cyanobacteria or blue-green algae that is going to be done jointly with some of our colleagues at York Public Health, as well as Sci-Fi Ontario. So please do look out for those notices and attend those. Other opportunities that we provide within our team include some education. We do have student practicums. We provide rotations for medical residents. And then, of course, we also provide field support in the way of not only discussing or supporting our colleagues when issues arise, but we do have an instrument loan program with a select number of instruments that we can provide to health units at request. That'll measure indoor air quality, for example, radio frequency. So we have worked in the past with several health units to provide those kinds of services and surveys in order to address local issues. And of course, the last is risk communication support. It's happened on a number of occasions, and I'll walk through a couple of the examples that we have where we've provided support. But at the heart of all these complicated issues is trying to risk communicate. So that is another area of support that we have provided to health units and to the Ministry of Health. So talked a little bit about the work that we do. And so what does a typical consultation look like? So most of them typically start with an email simply to our inbox. And so that's provided here on the screen. It's eoh@ohpp.ca. Those emails will come in and they get triaged and sent out to members of the team to respond. But we also say that there's no wrong door. So if you have a contact on our team and want to reach out directly, that's all right as well. It's just a little bit easier to remember what the inbox is. So in the last year, we've actually responded to over 660 requests, which is remarkable to know the kind of interactions we're having with all of you. And we hope to continue to have those interactions. One of the things that has been very important for us, and one of our learnings as we work with our partners, has been to try to scope the issue. There are a couple of questions that have come in over time that are quick responses, where other ones are more complex and require some thought and discussion between parties. So typically what that looks like is we'll have a phone call or a meeting to understand the kind of issue that the health unit is dealing with, and also what kind of support that you may need. As we can all imagine, it really varies from a simple response to perhaps attending a meeting or helping to peer review something that the health unit has done. So understanding how a response is going to be used is really important to us so that we can provide the best support possible in the situation that the health unit might find itself in. We do rely very heavily on the health units, as you are the local experts, to understand what is going on and any kind of feedback you're getting from the community and any kind of scenario that needs to be addressed that we wouldn't be privy to, given the nature of our role. So we do really encourage that scoping, and I'm sure as many of you are on the phone who hopefully have made requests to our team know, we do try to think of it as like just an open dialogue to really try to understand the issue better so that we can best support you and come up with what kind of a product will be the best. We really recognize that the response is a situation where not one size fits all. So we try to really address that and work together to get that done. So what will a response look like from us once it does come in? Um, Sort of talked about the different kinds of products and how we've provided support over time. And those responses will vary. Sometimes it'll be an evidence review. Sometimes, again, although we don't set standards or guidelines, we can work with you to help with the interpretation of those standards or guidelines. We can also draw in partners from the Ministry of Environment as needed to help explain those. We have worked with health units on data interpretation. We've also worked with them on feedback and support to response plans and activities, whether it's a community meeting or board meetings. And sometimes it's a combination of all of them, because as we've mentioned, and as we'll learn today, these issues can be very complex and can be multi-phases. We've had supports where we've worked with health units that have spanned years just due to the nature of the topic and the involvement and the interest from the public. So a couple of things that we have done over time are our work on perfluoroalkylated substances, or PFAS, also known as forever chemicals. This has been an interesting topic where the science is always evolving, and um, there's not a concrete answer in terms of what the health effects are associated with PFAS. Although that body of literature is growing, what we've heard from health units that have been affected by this um, is that there is a challenge in communicating uncertainty. So when the science is evolving, trying to give answers or trying to address people's concerns can be very challenging. So we have tried to be good partners and provide transparent scientific evidence with respect to what is evolving in that area. And sometimes that'll take the form of an evidence review. And I will also just mention that for PFAS, there is an upcoming updated focus on coming to our website soon. But also we've tailored fact sheets and other communication materials that health units have needed to get information out and address local concerns. We've also done that for things like blue-green algae, cyanobacteria, and again, hopefully some of you will tune into our June webinar series and hear about that and understand that better. And of course, something like radio frequency, which is, again, something that people are concerned about, but perhaps have a lot of questions about, that can be answered, whether it's through a survey or evidence reviews, is something that we have supported on before. These are just some recent examples, but there are much more. There's more on the slide as well. And the best advice is to not hesitate if you have an issue to please reach out to us, and if we can support you in any way, and or even sometimes connect you with another group within Public Health Ontario to address these, we'd be more than happy to. And with that, I will hand it over to Elena. Thank you so much.
Thank you, Rena. It is now my pleasure to introduce Dr. Ray Copes. Ray has worked extensively in occupational and environmental medicine, holding senior public health roles across Canada. He has worked with the British Columbia Ministry of Health and the BC Centre for Disease Control, where he served as the founding director of an organization many of us know quite well, the National Collaborating Centre for Environmental Health, or NCCEH. In 2009, Ray moved to Ontario to establish our team, the Environmental and Occupational Health team here at Public Health Ontario, and he has continued to contribute to the field through various local and provincial health initiatives following his departure from PHO in 2020. Ray, over to you.
Thanks very much, Elena, and it's great to be part of a PHO event again. Certainly miss all of my old colleagues, and I guess in the interim, since my departure, there are probably a lot of new ones out there. So this morning, I'm going to speak on risky business, a brief introduction to risk communication for public health. Why is it risky business? Well, having been to many public meetings over the years, I've watched public health staff on occasion struggle with communicating with the public, and sometimes things have not gone anywhere near as well as they could have if there'd been a little more understanding of some of the differences in how the public perceives risk versus how we as scientific and technical and public health professionals use some of these same terms. So we've only got an hour. This will be just a taste. And I think Rena hinted that, you know, we used to do full day or half day workshops on this and many other topics. And I guess now that we have come sufficiently far from COVID, there's perhaps some opportunity to do those kind of presentations on request again, if Rena and her colleagues are indeed available and there is interest. So let's talk about learning objectives. I was always taught at PHO we had to have these, so you should be able to describe and differentiate between risk assessment, risk management, list of important factors, influence public perceptions of risk, and discuss a framework for types of risk communication that are useful in public health and when to apply them. So moving on, let's look at some risk terminology and frameworks that are typically used by folks like us, scientific professionals, health protection organizations. And that's just to get us oriented to how we usually use some of these terms. And then in the last half of the presentation, do a bit of a contrast with how the broader society views these terms. So risk, this definition ought to be familiar to many of you. Characteristic of a situation or action wherein two or more outcomes are possible. Particular outcome that will occur is unknown. At least one of the possibilities is undesired. So usually when we talk about risk, we say that at a minimum, it has two dimensions. There's a probability and an adverse outcome or something we don't want to happen. So if we're not talking at a minimum of probability and an outcome, we don't have risk. Risk is not a number. There needs to be a consequence associated with the probability. Risk assessment, we need to try and make some sort of order out of chaos. And if we didn't have some sort of a system for assessing risks, we would be in much more difficulty than we are having a systematic process to describe and quantify risk that may be associated with hazardous substances, so chemicals or processes, actions, or events. This is a very broad definition of risk, and it goes far beyond what many folks do in the way of chemical hazard or biohazard risk assessment, and looks at a whole variety of different processes or events that may result in untoward consequences. So if we don't like or we are concerned about the level of risk existing, we manage risks. And risk management is fundamentally different than risk assessment in that it is the steps taken to alter or reduce levels of risk to which an individual or population is subject. And this involves the management, decision-making, active control, hazard control process to deal with various agents in the environment where we have done an evaluation or a risk assessment. So you can see from that risk assessment would precede risk management. Some other key points, and I like to stress this, is that risk assessment is fundamentally descriptive. It paints a picture for us. It doesn't say we have to do anything. The risk management is prescriptive. We are not satisfied with that picture that risk assessment has painted of a current state of affairs. We wish to change it, and we are going to take action to change the level of risk that is present. So risk assessment, risk management may be done by the same or different groups within a single agency or across different agencies. There are all sorts of different models out there. And the other thing is that really when we talk about risk assessment, it should inform decision makers. It really doesn't foreclose or eliminate options. Risk management policy and those folks who are managing the risk may choose to foreclose or eliminate options. But risk assessment per se does not do that. Another really important takeaway is don't confuse risk with compliance or non-compliance to a standard. The standards come out of our risk management process, and because we need to take action if a standard is not met, standards are often comply or non-comply binary. In other words, you're in compliance or you're not compliant. You are, obeying the speed limit or you are above the speed limit. Risk, on the other hand, tends to be a continuum. And obviously, if we are a little bit over the speed limit, we may be non-compliant, but the level of risk of an adverse outcome, an accident, may not be appreciably different than if we are driving a little bit below the speed limit. If, on the other hand, we're doing double the speed limit, probably our level of risk is considerably higher than if we were in compliance with the speed limit. So again, think about compliance and non-compliance as being very different than risk. So don't confuse a compliance assessment with a risk assessment. And again, in public meetings, this is often an important point to make. And I think if you use the right analogies, that the public has a pretty good intuitive feel for risk being a continuum and standards being either complied with or not. So this is a risk assessment and management framework. This is one that many of you will find familiar, that, risk assessment, the systematic process, is really a use of scientific information rather than science per se. So here in this diagram, we've got research on the left-hand side, various studies in toxicology, genomics, lab and field measurements. So that's kind of the underlying science that gets used in risk assessment. And you can see that there are two arrows there, research leading into risk assessment, and then questions from risk assessment identifying further research needs. So I like those two arrows at the interface of research and risk assessment. Risk assessment, as many of you know, is fundamentally a four-step process: hazard identification, dose response assessment, exposure assessment, risk characterization. At least this is for chemical hazards and biohazards and radiation hazards. Risk management, development of the options, evaluation of, public health, economic, social, political context for risk management, and then the policy actions or decisions coming out at the bottom of that. A more generic framework for risk analysis and risk assessment, you can see the similarities here, though, is this model here. And I think this one applies far more widely to risks in the environment that go beyond simply chemical hazards. So uses of risk assessment, I've listed some of them here. We use it for everything from standard setting to risk ranking, setting priorities, burden of illness. PHO did a lot of that work some time ago to try and contextualize different risks. And we can use it to balance benefits and risks and estimate residual risks after we take our risk management actions, compare those to initial level of risk before we undertook any kind of action or risk management. And good risk management, there's some hallmarks here. So, we should know what risk it is we are assessing. So doing a good risk assessment before you move into risk management is pretty important. As the physicians in the audience were taught, primum non nocere, so do more good than harm. Look at the lowest net risk, the problem of risk-risk trade-offs, and reducing one risk and increasing other risks is well documented in the literature and practice. The risk management needs to be doable. It needs to be cost effective. There needs to be some socio-political will to implement the risk management measures. It needs to be measurable. So have you achieved the standard or not? And there should be evaluation or feedback as to whether you've been successful in achieving your targets or not. And I'm afraid that last step is one that may often be overlooked in risk management. What do we do to manage risks? Well, those of you in the policy area are familiar with probably a ladder of interventions. So we exhort people to do things. We provide incentives, subsidies, we provide economic sanctions or fines. We may regulate, and at the most extreme, we may ban something. This is a ladder of interventions that, again, some of you will be familiar with, the Nuffield intervention ladder. Doing nothing at the bottom there is certainly, one option in risk management. And there may be times where after a risk assessment, you decide doing nothing or simply monitoring the current situation is the best state of affairs. Then moving upwards from that, providing information, trying to inform and educate people, go out, get immunized, stop smoking, take the bus to work rather than driving, or, use active transportation rather than driving. We can, enable choice if we think that people really don't have the option of active transportation or, adequate public transit. We can take steps to enable that choice, and we can provide various levels of incentive and sanction for making one choice versus another. And then up at the top there, you see the ban or eliminating choice altogether, and not allowing people to engage in a certain behavior or use certain products. So what are some of the challenges in risk management? We've got a lot of organizations involved in managing various risks. So in some cases, risks are managed in isolation, either because one ministry or government department or one level of government versus another as different policy choices in managing risks may also vary within and across media. So typically radiation regulators have chosen target risk levels for things like cancer on the order of 1 in 10,000. Chemical regulators, on the other hand, have typically targeted residual cancer risk levels on the order of roughly 1 in a million. So this leads to some very interesting differences in how we manage risks in something like, say, drinking water, where you're looking at chemical risks versus radiological risks. How internally consistent are organizations and how they manage risk? Certainly looking at the old health protection branch in Health Canada, the folks managing the blood supply versus the folks who were setting drinking water standards had very different approaches to managing risk. And the tainted blood scandal that came out, I think, was one very clear example of how even within one organization, there might be quite different approaches to risk management. And there are different policies and approaches used on the technical side in risk assessment that lead into differences in risk management in different organizations too. And sometimes environmental health risks are treated as public health problems in isolation and not placed in the context of other public health problems. So, the foregoing framework, what we've been talking about, this is good, technical, solid risk assessment and risk management. These, this framework is used by regulators, technical professionals, academics. So folks like us, it provides a really useful basis for us to engage in communication about risk issues within our community. So if we didn't understand these concepts, we wouldn't be able to talk among ourselves about risk assessment, risk management, and what it is we're doing. So really important that we have this framework for communication. However, now for the bad news. The foregoing terms and concepts, not particularly helpful in my experience and the experience of many others in understanding the perception of risk in wider society, and not particularly helpful in communicating about risk with people outside the risk or the scientific and technical community. And why is this important? Well, there are a heck of a lot more people not like us than like us. So, the population, if you will, of scientific and technical professionals, regulators, academics, risk managers, risk assessors is overall a pretty small group. And there are far more people out there in the public than there are folks like us. So pretty important that we as the sort of practitioners and the folks who have technical knowledge are able to communicate with folks who are not like us. That was the bad news. So the good news is that there's been considerable research and a lot of practical experience in understanding how most people perceive risk and how this can facilitate effective risk communication. Risk can really be viewed as a social construct, not just a technical one. And all what we've been discussing so far have been sort of technical constructs of risk. And there are many researchers and practitioners in the field, among them, Sheila Jasanoff, Paul Slovic, Vince Cavello, Peter Sandman. And although they have slightly different, models and approaches, there's a lot of similarity between these. So, here's one way of conceptualizing risk, and I apologize. I think these are probably, the font is probably too small to really look at this, but you will get the slide deck later, and you can look at it in more detail. And this sort of risk space is a two-dimensional, which is, not particularly sophisticated, having only two dimensions, and it places a whole variety of different risks on two axes. One is observable, not observable. The other is controllable, uncontrollable. And generally speaking, the uncontrollable, unobservable risks are viewed with greater dread or seriousness, and often come in for more stringent regulation than risks that are controllable and observable. So that's one way of looking at or trying to place a variety of risks. But there's, I think, a far richer and a far more useful way of looking at risk in public health protection. And this comes from Peter Sandman. I've given you the web address there, and he has a huge amount of material on risk perception, risk communication, a lot of quite relevant public health topics, including vaccines and communicable diseases, as well as chemical hazards. And I encourage you all to go to this website. Peter is getting on in years, and there's not as much fresh material on that website now as there was when I was at Public Health Ontario. But Peter's sort of conception of risk is hazard plus outrage. Now, what he's referring to there is the hazard is essentially the technical risk, what it is that we've been talking about to date, and what we as sort of scientific and public health professionals would consider the risk. And then the other term is the outrage, or how the public views the risk. And this is additive, not multiplicative. You see the plus sign there. And in my experience and the experience of many others, this sort of public risk is often driven by the outrage factor far more than by the hazard factor. So in other words, we can have our technical assessment. We may be assessing the risk in terms of scientific terms, the hazard, and then we go out and we find, holy smokes, we thought we had a really small risk here, and the people are just incredibly upset about it. What's going on? That is the outrage. So, is risk assessment relevant? I would say yes. We need to be sure of what we are looking at in technical terms, but I would argue that our scientific and technical risk assessments are nowhere near sufficient to give us a proper understanding of how risks will be perceived by the public, as opposed to our technical relationship or technical assessment of the risk. So outrage management, if the hazard of the risk is low and the outrage is high, in sort of Peter Sandman's terms, you have a very large risk. And you need to be aware of that before you go out and communicate on the risk. So one of the interesting things, of course, that risks that harm us and those that upset us are very, very different. So when we're looking at how risks are perceived and reacted to versus the technical assessment of risk, the correlation is not very strong. This R squared of 0.04 that Peter Salmon gives in one of his videos is a bit apocryphal, but I think it's a good sort of numerical assessment of the relatively poor relationship between technical risk and perceived risk, and that is why it's relevant for public health. So again, our assessment, perception of the risk and the public's may be quite different. And our response, if we're not aware of this, to dealing with risks may in and of itself produce outrage. And I've seen that happen a number of times. This is the most important slide in the deck. So if you're looking at, which factors of risk, and none of these, of course, are quantitative. These aren't numbers. There's no equation here. But there are a number of terms here that you need to be aware of that, will skew perception of risk towards something that is safe or not particularly concerning or something that is risky. So here we see that voluntary risks tend to be seen as much safer than coerced risks. So the risks we choose to take on ourselves, not seen as anywhere near as quote, risky as those that are imposed on us by others. Natural risks, those things occurring naturally in the environment, are seen as far less risky than those that come from industrial sources or as a result of human activity. Risks that we're familiar with are perceived as safer than those that are exotic or novel to us. Memorable risks, seen as riskier than non-memorable risks. So, was there one particular explosion or event in our community that we remember? That is sort of the hallmark of a memorable risk. Dread, there's some things that we are more afraid of than others. Cancer tends to be a dreaded risk. Something like heart failure doesn't seem to, have the same kind of dread for, a physician diagnosing a person with heart failure in the office. That might not produce the same reaction as a diagnosis of cancer. If you look at the prognosis, though, in many cases, serious heart failure is more likely to shorten lives than certain types of cancers. Catastrophic risks, as opposed to ongoing risks, are perceived as riskier. Ones that we can know and understand, seen as safer than the unknowable ones. And here one, again, that's a bit like the voluntary, but incredibly important, individually controlled risks. If we can control that risk ourselves, that is seen as safer than risks that are controlled by others. And again, I would sort of work at this point the concept of trust into that and the amount of trust or lack of trust in the quote others who are controlling the risks. We do have sort of a system of ethics or morality that is embedded and in sort of our perception of risk. So is it fair or unfair? Who's bearing the risk? Who's benefiting from the risk? Really important in how that is viewed as well. Is it a risk that is morally relevant or not? Risks that have moral relevance tend to be seen as riskier. Trustworthy source, untrustworthy sources, and again, I'll come back to this at the end of the presentation. Trust is incredibly important. And if the people, organizations managing or controlling the risk or the source of the risk are seen as untrustworthy, you are going to have difficulties with public perception and acceptance. The process used to manage the risk and deal with it, is this a responsive process or an unresponsive process? So do people who are going to be subject to the risk have an opportunity to participate and influence the outcome of this process or not. So many years ago, I used to keep this, in my drawer, and any time someone would come running into my office with, the latest risk that they were concerned about, whether it was a colleague or whether it was a senior public servant, rather than doing a technical risk assessment, which I, of course, would do at some point, I would run through a list of outrage components, and that gave me a pretty good idea of whether this was going to be a hot issue or not in terms of how I had to provide advice, or how the organizations I was associated with had to be on their toes to make sure that they dealt with the public perceptions and reactions to the source of risk. So this one is in my view solid gold, and there are other lists similar to this, but I find this one works pretty well. So outrage factors, what I've just gone through here, these are the prime determinants of risk as perceived by the public. And even if there is little or no consequence of the risk from a technical perspective, or the severity of the consequence, these factors are really going to be the ones that drive how the public sees the risk. So please be aware of those, use those. I've found it incredibly helpful, and so have many others. How to, put this into some sort of framework then that allows us to think through the kind of communication that we need in response to, outrage or lack of outrage. So Peter Sandman's come up with this kind of twofold classification here. Risk equals hazard plus outrage. So hazard, the technical risk there along the x-axis, and the outrage, which is how the public views the risk. And he comes up with a number of types of risk communication that may be useful in public health. So, if we as sort of technical people don't think the risk is particularly high, but the public is outraged, we need to move into risk management, outrage management. The smiley face there in the middle is where, our assessment of the level of risk and the public's are roughly the same. So, we're on the same page there with the public. Precaution advocacy is when we think there is a relatively high risk, and we think as sort of scientific, technical, public health protection professionals that action needs to be taken to reduce the risk, and the public, not so sure. What's the big problem here? Why are you getting all excited as sort of public health or technical professionals about this risk? And that's where precaution advocacy comes in. And we know that the public certainly underestimates some types of risk. If we go back to the previous day, something like smoking, the level of risk there has been underestimated considerably by many folks. And again, certain communicable diseases, again, because they are far from public consciousness, so few cases, obviously measles being a recent exception to our past experience with that. People not particularly concerned about the risk of an infection, when we as public health professionals know darn well that all it takes is one case to set off an outbreak. Crisis communication, again, that's when both the risk and the outrage or public concern are roughly equivalent. Both are high, and that is a special type of risk communication there, because the level of concerns on both the public health professionals and the public are high. So let's consider these different quadrants and types of risk communication, remembering high outrage, low hazard, outrage management, high hazard, high outrage, crisis communication. And again, that's public perception of risk is high, professional perception or assessment of risk is high, precaution advocacy, public perception is low, and scientific and technical folks think it is high. This is the empty quarter here. Peter's been asked about that on occasion. He says everyone goes to sleep there because no one's concerned. That's the empty quarter, if you will. So how do you go about reducing outrage? If you're doing outrage management, the sort of upper left-hand quadrant we saw on the previous slide, stake out the middle, not the extreme. Acknowledge prior misbehavior. So even, if you are a company and you've got a bad environmental or health track record, it's better to acknowledge that than not. If you are a public health agency, and traditionally we think of ourselves as the good guys, and we have been unresponsive or unreceptive to public concerns in the past, best that we acknowledge that we have not always listened, we have not always responded to your concern about issue X, but we are now, and we recognize that we probably should have been engaging with you earlier on. Acknowledge current problems. I mean, everyone knows they're there, so it's far better to be candid than to pretend that there isn't that elephant or problem in the room. I mean, we all work for great organizations and we're all great folks, but we shouldn't be blowing our own horn. Better that others, tout how great we are rather than we do that ourselves. So be a bit humble. Sharing control and being accountable, really important. If you go into a room and say, well, trust me, that's going to probably on the part of some folks who have never met you before, or maybe even some that have, not produce a good response. If you say, hold us accountable, here's what we commit to do in response to this particular issue or this crisis, and hold us accountable, check back and see whether we've done it or not. That's something that folks are likely to view with far more favor and say, well, maybe these people aren't so bad after all. There is a lot of, unvoiced concerns, and there may be motives other than the official motive. Is this really about risk, or is this really about property values? Is this really about, I should be able to enjoy my property rather than, I think there is a health risk in locating this unwanted facility in my neighborhood or next door to me. So pay close attention to that. If you go back to the risky versus safe, sometimes you can put your finger on it and say, well, really this is more about fairness than about whether people are going to, develop illness or not. And sometimes that can be very helpful in opening up a door that is going to lead you to better communication and solutions. Precaution advocacy. So this is where we think there is something serious that needs to be addressed. The public is not so sure. Keep it short, make it interesting. Test your messages, and I can't emphasize this enough. And don't test your risk communication messages on your colleagues. Test them on your neighbors or your relatives who are not involved in public health or in risk assessment and risk management. You're looking for a lay assessment of your message here, not a fellow professional. Stay on message. Good precaution advocacy is rarely done in a day or a week or even a month. It takes time and repetition. Appeal to needs, and some of you who may have done psychology in undergrad, Maslow's hierarchy of needs is a really good framework to hang this on, and give people things to do. And if you can hook them at the low end of taking initial early steps, and then give them more and more to do, and move them along that continuum of action, that again can be helpful in certain circumstances. There are a lot of other tips on precaution advocacy, and as I say, we used to do day-long workshops, the various types of risk communication for outrage and for precaution. So risk communication, again, to summarize, goals are to share knowledge and understanding, build trust and credibility. And if you've got that in spades before you start, you are ahead of the game. And to facilitate cooperation and constructive dialogue. And again, risk communication, fundamentally a two-way process. It's not just we're here to tell you what we have, what we have found or what we are proposing. Some of the most effective public meetings I have been to have been ones where folks from the health units get up and say, well, here are our goals for the night. And, one of the really important ones is we want to hear from you because that's a really important part of our role as health unit and how we go about solving problems and taking actions in communities. So we are here to listen to you. And it is amazing how that can really diffuse some of the sort of pent-up concerns that I've seen on occasion when the moderator announces that we're here to listen to you as well as to share with you what knowledge, information we have here as public health. So, importance of trust. This is something I really want to kind of close off on. And we're probably aware of a lot of public opinion polling that has indicated a decline in trust in government, in public agencies, and decline in trust generally in various countries. So, I think it's really important for folks in public health to recognize that levels of trust that we're dealing with now are not what we may have had even 10, 20 years ago. This trend predates COVID, but I think COVID was a pretty significant event. And I think it's pretty fair to say that in many cases, or most cases, trust on the part of the public in public health and government was harmed by COVID. I like to think that here in Canada, we came off far better than some other countries, such as, for example, the UK or the US. But nonetheless, I think we certainly need to reflect on how some people may have a lower level of trust in us than they did before. So I would argue that building and rebuilding trusts with public is an important challenge for public health now, one that we shouldn't ignore and that we should reflect on. How can we increase the level of trust that the public have in us? Because we're good people. We know we're trustworthy. It's just that not everyone knows we're trustworthy, right? So trust is multidimensional, right? I think this is one really important finding. And of course, at Public Health Ontario, when I was there, we were very big on systematic reviews. I hope that is still true because I went to the trouble of finding a recent one on why and how we trust. And you can see the citation there. It's actually a chapter in a book. And if anyone needs that reference in detail, I can provide it later. So basically, this systematic review done last year confirmed earlier work by Mayer et al. That there are three main dimensions to trust. And that includes your ability, benevolence, and integrity. So, the ability or the perceived ability of an organization in terms of their competence, ability, their expertise is an important factor in deciding whether or not that organization and the individuals working there are trustworthy. And I like to think that, in public health, we've got a lot of, a workforce that's highly competent, expert in different areas. Important that we not pretend to be experts in things that we're not experts in and bring in the requisite expertise when that's true. Benevolence, are we in it for the public good, or, is our organization, whether it's ministry, Public Health Ontario, health units, are we looking after our organization's interests, or are we really in it for the public good? So, components of the benevolence, it's not just benevolence, it's also goodwill, care, concern. So, to what extent are we listening? To what extent are we empathetic? To what extent do we understand that maybe other perspectives are not the same as our own? A third major component of trust is integrity. So, do we or does our organization adhere to a set of principles? Are we seen as being honest, having integrity, being fair, and faith? Faith sounds a bit religious, but I think it's faith in what we're doing, and it may be religious, but of course, faith is far wider than just in deities. It's also sort of faith in what you're doing in terms of being principled and having an adherence to what it is that you believe in. So those are the three major components. I mean, if you do factor analysis or these other statistical things, you can come up with far more factors, but these are the three main axes. So that's why I give these to you out of the systematic review to reflect on. And, does your public see you and your organization as trustworthy on these dimensions? How sure are you about this? Do we need to improve our ratings on this? And trust is absolutely critical in effective risk communication. If folks don't trust you, doesn't matter, how you engage if you are not seen as being trustworthy. So, I just like to point out how important this is. These dimensions are similar to what other authors have described as attributes of credibility. So, for example, Frumkin, who's was Dean of Public Health at University of Washington, he says, "Are you credible? Trust in high stress situations." And he put some quantification on this. I'm not sure that this is true for all times, all places, but his argument is about half of it is probably the benevolence access that I gave you on the previous slide, 15 to 20% on probably the integrity access, and then 15 to 20% on the ability access. And then there are a few other things that he threw in there that he didn't put in the three main axes, and he gives them in total 15 to 20% too. So, if you're looking at what's really important, listening, caring, empathy, probably the benevolence one on the previous slide, maybe quantitatively the most important, but don't forget the others. And some points for reflection to close off. We love risk assessments. It's always nice to get into the technical details, but let's not kid ourselves. Insofar as risk assessments are precise, they are unrealistic most times. Insofar as risk assessments are realistic, they're imprecise. Risk assessment is a much better tool for comparing risk than estimating absolute levels of risk or comparing with a regulatory bright line, given the residual uncertainties in risk assessment. Technical aspects of risk, generally less important than its qualitative attributes in public perception of risk. I hope you understand that very, very well now. And uncertainty can be ignored. It won't go away. And how to deal with uncertainty and risk communication, really important. Perhaps we can talk a bit more about that in the questions. It's tough to do risk communication from far. I think folks in health units have got an inherent advantage here being local versus folks in Toronto or Ottawa. And trust is essential for effective risk communication. And organizations often react to risk perceptions rather than addressing them. So thank you. Questions? And oh my goodness, I've finished a minute early, so more time for questions.
Yes, we are right on time. Thank you so much, Ray. All right, so that was a very informative presentation. We're now going to go into our Q&A session. If you haven't already, please go ahead and submit your questions using that Q&A pod. Now, one of the advantages of moderating a session is that it gives me an opportunity to ask the first question. So to get us started, Ray, I'm going to ask you, what is one thing, or perhaps two or three things, I don't want to limit you, where you consistently see people getting it wrong when it comes to risk communication?
Yeah, I think because we are so socialized, in our schooling and our work in sort of a scientific and technical model of risk and risk assessment. that it's really, really difficult for us. And I mean, I've felt this myself, and I've seen it in others, to break out of this idea that somehow our model is superior or the real thing. And all of this sort of public perception of risk is somehow not as good or not as real as the scientific and technical stuff we do. I think that's wrong. It's just a very different way of looking at things. And if we want to be effective, we have to be fluent in both languages, and we have to be equally fluent, and we have to recognize that, you know, what we've learned and what we do is really, really important. But at the end of the day, it is not superior in terms of a framework for, you know, understanding and communicating about risk to the one that folks like Peter Sandman and the other people in sort of the you know, risk perception and more social science oriented worlds have presented. And there's some excellent old videos of Peter Sandman talking to audiences of very skeptical scientists and engineers, and you can just see the resistance there to, you know, letting go of the model that we're comfortable with and sort of switching over to this other way of thinking of things.
Great, thank you. All right, moving right along. So the next question that I'm going to read is right from our Q&A pod. So in regards to outrage management, wondering if you could please speak to how someone would put the risk into context, something like attributable risk, if they're dealing with an issue where we don't truly understand the risk yet. And so the example given here is ultrafine particles, something where the science is still very new, very much emerging. How would you approach calls for something like the precautionary principle to be used? Maybe someone wants to shut down an airport because of ultrafine particulates, as an example.
Wow, really good question. So, I mean, we could spend an hour on that one, but we can't. So, you know, recognize uncertainty. You know, it's almost always there, but it's really important to place bounds on it. So, you know, if you think about a complete lack of knowledge, you know, literally anything could happen. And we may be uncertain as to what exactly is going to happen or what the exact risk is attributable to ultrafine particles, but we can place some bounds on that. So I think that helps to contextualize it. The other thing to point out is that even though we are not, at this point, to my knowledge, regulating ultrafine particles, we do regulate other fractions of particles, and ultrafines are a wholly included subset of that. So, you know, reassure folks that this is not an unaddressed risk. Point out, you know, and when we recognize that we are uncertain, it's also helpful to say, and we know there's a knowledge gap there, and here's what we're doing to go about filling in that piece. And, you know, folks take far more comfort in one, recognizing that you know you don't know everything, but that you are going to take action based on that lack of knowledge, and you are actively trying to fill in gaps in what is not known, and you are trying to reduce that uncertainty so that you can better protect the public. With respect to, you know, shutting down an airport because of ultrafines, you know, there are a lot of benefits that come from that airport as well. And I don't know the particular airport you have in mind, but looking at risks versus, you know, the risk of doing something versus the risk of not doing something. So you may not shut down the airport. There is maybe a risk from aircraft emissions, but if you shut down that airport, that opens up a whole new set of risks. And I remember one meeting many years ago, not on ultrafines, but on fine particulates. So PM2.5 was the big thing then. And one very outraged woman in the audience who tore a strip off me, or well, I should say public health and the environmental regulator for, you know, how can you stand up there and recognize that fine particles have this effect on our health, that you cannot provide any number at which there is zero risk. how can you allow any of these emissions to occur in our community and place our health at risk? And this woman was very adamant. And, I think, the folks at the platform party had to be apologetic and say, well, we, in an ideal world, we wouldn't have any risks. However, if you take a look at the sources of fine particles in your community, it comes from, a variety of sources. It comes from the wood that your neighbors are burning to keep warm in the winter. It comes from one of the local mills, which provides jobs to many people in this community. It comes from the vehicles that we are using every day, whether it's to go shopping, to visit relatives, to attend medical appointments. And if we could get everyone to agree to eliminate all those activities, we could get down to what you hope defined as zero risk from fine particles. Unfortunately, I don't think we would get the agreement of everyone here in this room that those actions are, acceptable in the eyes of the community to eliminate the particulate hazard. And, then I gave a sort of nod to my colleague who is the environmental regulator and said, and, Mr. So-and-so is really in a tough position because on the one hand, he's trying to protect the environment and public health. On the other hand, getting to zero is simply not a realistic. And you know what? The woman actually seemed satisfied with the answer. And of course, everyone in the audience, no one was willing to stop burning wood. No one wanted the mill to shut down and eliminate jobs, and no one wanted to stop driving. So context can be helpful, and so can risk trade-offs.
Absolutely. Thank you, Ray. For our next question, and this is one that's come up time and time again, especially coming out of the pandemic. What would be some strategies for risk communication for local public health units who are trying to address misinformation from sources like the media, also social media and websites?
Wow. Yeah, huge problem. I guess, putting your credibility on the line and being seen as the most credible or the preferred source of information, because there's no way we're going to shut down all of those other sources. And the way to build your credibility, I think, is to increase the level of trust that folks have in you and your organization versus the myriad of other sources out there. So that's why I incorporated the slides on trust in the deck here, because I think looking at how we can be seen as the most trustworthy source. We can't eliminate, the other sources of disinformation, misinformation, but we can point out that we understand where folks are coming from in terms of their concern, whether it's about, non-pharmaceutical interventions to reduce transmission of infectious disease, or whether it is through immunizations. We can recognize that vaccines aren't perfect, but by gosh, they're a whole lot better than no vaccine in almost any case you can imagine. So I think looking at, building your trust using the three main axes that were on one of the previous slides. And then, it's a matter of, in many cases, precaution advocacy. And that is, a whole area that we just barely touched on in this presentation, and look at what's known about how to be effective in precaution advocacy. I just gave you a very short list of some of the things to think about in your messaging on precaution advocacy. So I guess that's about all we can say for now, but Rena, we used to go out and we would, sometimes spend half a day on precaution advocacy, half a day on outreach management. And that was a lot of fun. There were a lot of learnings. And I think folks at the end of the day actually ended up with some sort of practical things that they could do and change and use to enhance the effectiveness of their messaging.
Perfect. For the next question, this one's really about, what role does additional data play in ongoing risk communication? So there is kind of an example here. So if the local public health unit has decided to support something like a solid waste incinerator, the environmental assessment, but has noted that, superior air quality standards need to be adopted, and also a robust environmental surveillance program has to be put in place. Having that surveillance program moving forward, having that continued data and learning, what kind of role would that play in continued risk communication?
Really good point. And I think it, personally, I think it plays a really important one. And I think that gets back to, what I put on one of the slides about and hold us accountable. I've been in many controversies where, something is yet to be built. We have models, we have predictions, we have projections, and there is uncertainty associated with all of those. We know it. The consultants doing the studies know it. The regulator knows it, and the public knows it. So, I think we need to kind of put our money where our mouth is and say, and hold us accountable for delivering on the performance that this proponent or this facility has said they can deliver. And we are going to monitor and we are going to share those results so that we can hold the proponent accountable for, delivering the level of performance they've committed to, so that the consultants with their predictions are held accountable for the, validity or reliability of those predictions. And we, as your local public health staff, who obviously have public health interest and protection at heart, want to see those numbers too, because we want to ensure that there's a satisfactory level of protection for public health. So I think it fits very nicely with trust, holding people accountable. Don't just believe us and take it at face value, but we are going to demonstrate to you and we are going to share those results with you. So I think it's a really important factor to consider in many of these applications.
Yeah. All right, we're going to try and squeeze in just one last question, because I do note that we're nearing the end of our session today. So this one is one for me. So just in reflecting on the many years we worked together, Ray, one topic that came up time and time again was that of, non-communicable disease clusters and perceived concerns or perceived, issues that were being reported to local public health, where, although it was being reported as a perceived increase in illness or disease or mortality, after, we would engage in information gathering with our local public health colleagues, we would often learn that there was a long-standing environmental concern that was kind of playing a role behind the scenes. Although something had been reported to public health as a health concern, it was really about air quality, about, maybe proximity to industry or a point source. What should one consider when trying to, approach something in a very, risk communication way, when you suspect that, that there might be some underlying concerns that aren't really lining up with what's been reported?
I think it gets back to the slide about, unvoiced concerns. And that's why I think it's fundamental that risk communication is two-way. Because unless you're out there listening to folks, you may miss those, concerns that aren't really on the table. I'd also say, acknowledging prior misbehavior. And, I think in some cases on these clusters, health units have not responded as promptly as they could have, or I would argue maybe even should have. So that's where I think recognizing, we're here now. We want to listen to you. We want to take action and investigate. And we recognize that, this has been a concern or has been brought forward now for 3 years. And we should have really been at this stage some years ago. So we are sorry, but that's behind us. What's ahead of us now is to investigate your concerns about potential clusters. And we also hear concern about, facility A, B, and C. And in tandem with our investigation of the health concerns, we are going to check with the environmental regulators and make sure that these facilities are indeed meeting the requirements with respect to their emissions. And even if, levels are not at the point where we'd expect however many cancers, illnesses, those facilities need to be in compliance. And here is again where I would differentiate the risk from the compliance. They need to be in compliance with their permits. That we need to be in compliance with air quality standards because we expect people to follow the law. Right?
Fantastic. Thank you. All right, with that, as we conclude today's webinar, I would like to again extend our thank you to Rena and Ray for joining us, and Ray for a highly, informative and engaging presentation. Of course, a sincere thank you to all of you who joined us today. Finally, a reminder that you will receive a brief anonymous survey following today's session. It does include questions asking for your input on topics for future in-person workshops navigating environmental health issues. We encourage you to take a few moments to complete it, as your feedback is invaluable in helping us strengthen and shape in future programming. With that, thank you once again, and we wish everyone a wonderful Friday.
Thank you all. It's been a pleasure.